The field studies lecture series was created to create a forum, a place where students who go out and have really good experiences and then go on with their lives can return back here to their alma mater and be able to explain and describe what has been their experience. And I think, unfortunately, we live in a society where we don't tell our stories enough, We don't really have communication enough about what we've done with our life and what maybe our feelings are. In an academic setting like this, sometimes we try to make it just too academic. And there's, I think, some real value in students and others being able to come and listen to the path that someone has taken and see how they went from here to there. And we hope that it will be useful for you today. Sarah is really, she's the epitome. She's the ideal for an opener for the field study lecture series for this year. And we do wish there were more people, and it has absolutely nothing to do with Sarah. It has everything to do with the fact that at universities like this we are so busy, and then getting the word out and getting people to realize that this is going to be happening on Fridays at noontime is more just as kind of our fault and an institutional challenge that we have. But I think it's ideal to have Sarah here with us today in this setting. With this audience. She you started school here in the mid-90s, 96, 97, 97 or so, because in 99 was the first time that she went on a field study. And I remember actually talking to you and having an interview and having multiple discussions when she was getting selected and prepared to go to Tanzania that first time. And we always know we have somewhat unique individuals that come to us because not everybody wants to go live in a village somewhere in a developing country where life is a challenge. But Sarah really, in so many ways, was the ideal field study student. Sarah has a certain level of quiet confidence about her. We realized this after her first field experience and asked her to go back to be a field facilitator, a team leader. And then that was in 2001. You graduated and went on back east to Yale. She is presently working on a master's degree in public health. Is that correct? And her husband, Justin, who unfortunately wasn't able to be here, as well as Juma, her baby, who's not a baby anymore. He's like 4, so it's probably best he's not here because he'd be like stacking the chairs and swinging. Cute baby, and he's probably still speaking gibberish cross between English and Swahili and probably Spanish and other things. I'm not sure what. But Sarah takes very seriously the issues of the present-day world and the cross-cultural issues and some of the challenges that we, the human race, have some of the situations we've got ourselves into. And I think she's going to make an amazing contribution. She's subsequently gone back another 2 times to Tanzania, from what I understand, and we've had a little bit of email communication during those experiences, but I'm kind of interested and excited to hear about what those have yielded as well. And so with that, it's just my pleasure to introduce to you Sarah Beckham.
Thank you, Ashley and Dave. It's nice and a little strange to be back, but it's nice, and I'm glad to have this opportunity to see old friends and professors and family. So let's just get started. And I have to look here to see the screen. Okay, that's fine. Okay, my title, from malaria patient to public health professional, is perhaps a little facetious because I'm not quite a public health professional, but I hope to be in another couple of years when I get my degree. And the malaria patient part I'll get into. This picture is a painting made by a local artist in Zanzibar that I've seen for years, and I just said I have to have it, so my husband got it for my birthday this year, showing the local hospital there and just having a little fun with art. Okay, so to locate my field studies and my trips, I was in Africa. There on the East Coast, both Kenya and Tanzania are highlighted. I think this map is from when the embassies were bombed in those countries, but I was just in Tanzania, Tanzania specifically, and then here on the coast, along here is the Swahili coast, and here Zanzibar or Unguja Island, which is where I was the first 3 trips, and then Pemba Island, which is where I was this last summer, and I'll get more specific on that as well. Like right now, here's a close-up of Unguja Island and of Pemba. Okay, I'm going to just go through an overview of my field studies, going over where I was, what I did, and it's kind of a highlight of some main findings. And then kind of the broad lessons learned from each of the trips. And then just to spice things up a little bit, I'll go through some highlights of like fun stuff I did while I was there, because field studies aren't all research. And just to show you some pictures to keep things a little interesting. And then I'll go like an overview of my summer research, which hopefully will be my thesis. Okay, in '99, I was located in Unguja Island in Makunduchi village that was just circled right down there, way down in the south. So on the island, there's a city here, which is the only city on the island, so we had to take a local bus down here, and it took about 2 hours, I think. Did it take about 2 hours, Julie? Something like that? Okay.
Zanzibar City or Stone Town, right?
Right, Stone Town is the city there.
What's the population there?
The population of both islands is about maybe 750,000, and Stone Town, with all the suburbs, is probably 300,000, maybe. Okay, as far as method goes that year, I interviewed 25 mothers, biomedical and local doctors, as in traditional healers, and some nurses. I did a literature review. I used participant observation in hospitals and treatments, and unfortunately I also went through a personal experience of having malaria for 5 weeks. So this is what was the defining moment of my, like, launching my career interests, is when I got malaria and decided that public health was something that I wanted to be involved in and study. Right. That's one of those things, you don't write home about until I was really desperate. Then we were like, okay, pray for us. Yeah. Okay. Overall, some of the findings. In Zanzibar as a whole, at any given time, 1/3 of the people have malaria parasites in their body. Not all of them are symptomatic, but they all should be treated. It's the #1 cause of sickness and death in Zanzibar, especially in children under 5. And in Makunduchi district, there's a regional hospital there in the village I was in. So anywhere from 1,000 to 6,000 cases are diagnosed per month, just from looking at the hospital statistics. In the rainy season, it's higher. In the dry season, it's lower. And it accounts for 30% of all hospital visits, not just in Makunduchi, but in the whole area. And then I guess what was my main discovery was this dichotomy of malaria versus what Swahili called homa ya mdudu, which is fever of the bug or the pest. And so malaria was seen as primarily a Western disease that came when the colonists came. Like, white people brought malaria, and it was a simple fever that could be treated with drugs at the hospital. But then there was homa ya mdudu, which was there since before the white people, which involved delirium, convulsions, unconsciousness, and was a spirit-caused disease rather than a like a mosquito-caused disease. So instead of going to the hospital for treatment, people were more likely to go to a diviner or spiritual healer to address the cause of the spirit that had infected, particularly the child. And in the West, we might call this malaria versus cerebral malaria, which is the more severe case. So lessons learned overall, I learned that public health is important and that I wanted to be involved in it. And some fixes for the problem would be for more education for people and doctors, funding for appropriate measures, prevention such as using bed nets and bed nets that are impregnated with mosquito, I'm thinking in Swahili now, mosquito medicine, and to drain swamps and stuff like that, and to eradicate mosquitoes in general, as they did in the U.S. We used to have malaria in the U.S., and it was a matter of eradicating all the malaria-carrying mosquitoes to get rid of it. But I also learned that something is lost in the translation of these Western interventions, that oftentimes there's a lack of awareness of local needs and attitudes and knowledge and culture, such as this malaria versus homayamdudu. So just some of the more direct superficial measures won't get into the deep cultural aspects of this that are important to really change public health. Oh, and that's Juma, by the way, this summer on his bed. Yeah, that's a mosquito net. They're blue because mosquitoes like the color blue. So it attracts them, and then it's been impregnated with permethrin, so it's supposed to kill the mosquitoes on contact. So, and for fun, some of the other things I did in '99, I attended a few weddings. Here's some women having some fun making the wedding food.
It's like beer, is that?
It's rice. Muslims not drinking the beer here. I got henna applied. All my girlfriends wanted to do henna. And then just being in a place that had such a rich history. There's ruins in Zanzibar and Pemba that date from 1,000 years ago, mosques and palaces and stuff. Chinese pottery from like 800 years ago. It's pretty cool. And then, of course, just making friends. And this woman I've gone back to visit every year, and she still like remembers me and thinks, oh, when is Sarah going to come back? And then one day I just show up in her house and say hello. Okay, so then, as Dave said, I loved going to Tanzania so much on the field study, I wanted to go back. So I talked to Dave to become a field facilitator, and Justin and I went back and took 5 students with us, I think. But this time we went to the northeast coast to a village called Matemwe. But before I went, the first time I hadn't planned on studying malaria, of course, so I didn't know anything about it or about public health or anything. So this time before going, I took some classes. I did some reading in malaria, medical anthropology, microbiology, and public health to get myself educated so I could do a little more focused study. And so while there, I did interviews of doctors, nurses, village mothers, and people from the general population. So one main finding of this study was sort of a broad overview of how public health works in Zanzibar. So I won't spend too much time on this, but here in Matemwe, if someone got sick, say with cerebral malaria, they would go to this village dispensary where there was 1 community health nurse and 2 nurse midwives. But they have no laboratory, no microscope to positively test for malaria. And they have no beds or IVs or anything for a severe case. So if a doctor here suspected that someone had severe malaria, he or she would send them across the island here, where there was a second-tier hospital where they actually had microscopes and drugs to give for, like injections of quinine or whatever, to give for malaria. But if it was still a more complicated case, say the malaria led to anemia or major dehydration or kidney failure, then they would send them to Zanzibar town, where there's a hospital, and actually the only place both islands that actually have MDs. And they have inpatient wards and all of that, but it's still the kind of hospital where I wouldn't want to go myself. Broader lessons learned. The cause determines treatment. So I was talking about that a little bit with Homayam Dudu, where if it's caused by a spirit, you want to address the spirit cause. But if it's a parasite, which is what we define it in the West, then you'll use pharmaceuticals to treat it. But if it's seen as caused by a spirit, then you use divination or spirit healing to deal with it. And you can consider that something of a metaphor on how to deal with, how to define why someone gets sick or versus another person. And a metaphor we use in the West often is like a broken engine part. We kind of think of the body as a machine where there's different parts, and if one part stops working, you zoom in on that part and fix it. And there's less of a holistic look at the body. So when you get Zanzibari medicine and Western medicine, they sometimes clash because they may not operate on the same metaphors or conceptual basis. So while in the U.S., when someone gets sick, we usually isolate that individual and even go into the individual, into their lung or into their stomach or into their leg, and just fix that part. While in Zanzibar and many other places, health is a much broader thing where it involves not just the whole body, but the whole community. So if someone's sick, it may be not just they got malaria parasites in their blood, but that something went wrong in the whole community, like that person's mother offended her father-in-law, and so the community dynamic is messed up, and so people get sick. So addressing that whole community dynamic is what needs to be taken care of in order to cure a disease. So it's a little different. Okay, highlights from this year. This is at a festival called Mwakakogwa, where the people from Makunduchi fight each other with banana sticks. It's like a New Year's festival. I learned how to farm seaweed. Women farm seaweed and then sell it to someone who sells it to Japan, and they get a little bit of money for it. And then just being with great people and playing on the beach. So in 2004, I went back to Zanzibar. This is while I was not yet in grad school, but my husband was in grad school, so we were going for his project. So I didn't have a project of my own this time. I went to be a mom and to get to know Zanzibari language and culture and learn what it is to be Zanzibari a little bit better. So I was there in Zanzibar town that time, and I'll show you some pictures in a second. Yeah, here they are. Zanzibar town is about 200 years old. It was built mostly by Arabs from Oman when clove production started up in Zanzibar. And it's just an amazing city to be in and get lost in and walk around. There's just these narrow, winding streets, and it just has this great ambiance to it. It's just a fun place to be. When I arrive there, I feel like, I'm home. It's like a second home to me. And so we learned how to be, just a sort of an anthropological experience for me to learn how to be a Zanzibari woman, learn how to cook, how to dress.
Did you wear hijab?
I did. I did dress like this that summer and this last summer, when outside of the house. And then, of course, I was taking care of my son that summer. He's a cutie. Okay, so this summer, up to speed, we decided to move to Pemba Island, which has been, because of political reasons, has been closed off to the West and to researchers and tourism until very recently, like past 10, 15 years. So very little has been done on it in history, which is what my husband studies. There's been one dissertation written on Pemban history and no books. And there's been very little done in the field of public health, so it's kind of this gold mine for us to go there and be, pave ground. So Pemba there, along the coast of Tanzania, is north of the other island, up near the border of Kenya. So we were here in the city called Chake Chake, which was built in colonial times in the British. But my research covered a broader area of villages outside of Chake Chake. So I traveled around a bit. So setting up for this research, I have to do some acknowledgments. I got funding from the Lindsay Fellowship for Research in Africa, which was through Yale. My research colleague was Sarah Young, a PhD student at Cornell in nutritional anthropology. We got permission from the Ministry of Health of Zanzibar, and the basic study was on maternal anemia, barriers to treatment, and local perceptions of causes. So just to give you some background on maternal anemia, I'm assuming most people are not familiar with it. It's characterized by shortness of breath, dizziness, chronic fatigue, headache, and paleness of the skin, especially the palms, the eyes here, and like the lip. So you can pretty well diagnose someone just based on the coloration. It leads to problems or even death during delivery, and because of low red blood cells, therefore low oxygen to the baby's often born low birth weight, if not stillbirth. And it's readily preventable and treatable with nutrition and iron supplements or blood transfusions in really severe cases. More background specifically for Pemba. In one study, they found that 70% of Pemban women are anemic and 20% are severely anemic. And that's not even pregnant women, because pregnancy, it's worse. So for pregnant women, it's higher. And an estimated 50% of maternal deaths are due to anemia, because during delivery, you lose a lot of blood, and if you're already low in blood supply, it's really bad. So the question is, if it's preventable and treatable, why are women and infants dying in Pemba and in other parts of the world? I think in India it's the worst cases of anemia. So going back to my old professor and mentor, Dave Schuler, I've defined the Schuler's squiggly lines model of constraints. So there's people who have free will and ability to make choices, but social, political, economic, cultural, and structural factors inhibit a person's ability to make choices, even given knowledge about appropriate choices. So sometimes we know what we need to do, but we're constrained for various reasons. Like, how many of you know how much you're supposed to be exercising and how many fruits and vegetables you're supposed to be eating? But guess what? There's probably 2 people in the room that actually do it all. So with the squiggly lines, we have people, but there's all these constraints pushing down on them, reducing their ability to make choices. And so this study was all about that. So I was stationed at a hospital maternity clinic in Chake Chake Hospital, but made forays into villages to follow up with severely anemic women. I interviewed 20 anemic pregnant women, 5 non-pregnant women, the 4 clinic nurses, 1 lay midwife, and then did informal interviews and observations in the clinic, in the pharmacy, in the hospital, and in the laboratory. And then I also recorded statistics on drugs dispensed, like iron and folic acid dispensed in the pharmacy, hemoglobin levels, which is an indication of anemia, and inpatient admittances, as in how many people were admitted for severe anemia in the past 2 years in this hospital. So a quantitative finding we have is just the hemoglobin, the HB, of the women. So we took just all the women that came to the clinic, we asked them, can we measure your HB? Got it measured and recorded it all. And this is how it works. You prick the finger, and then there's a little booklet called the hemoglobin scale, and inside there's blotting paper, and in the back there's this chart of different colors of blood. So you take the blotting paper and hold it behind the chart to compare colors of blood. So in the absence of not microscopes, but machines to measure HB, this is what is used. And it's got an error rate of plus or minus 5%, so It's an estimate, but if someone's severely anemic, you're going to know it by the color of their blood. So out of these 61 women, the average was 68%. So there's two different scales for hemoglobin. The one we use here mostly is a scale that healthy hemoglobin is 12 or above, and unhealthy is below. But because they're using this method, they go by percentages. So basically, you can interpret it as a woman who has a hemoglobin of 68 has 68% of the red blood cells she needs. Okay, so 80% and above is considered healthy. So the range of these women was from 50 to 80. So anything below 50, you need to be talking to a doctor about a transfusion. So out of all these women, 95% of them were anemic, of these pregnant women, and only 3 were not. 3 had hemoglobins of 80. So it was borderline still. And these were like city women, so they were the richer women of the island. And if we had done this in a village, it would have been much worse. So we know that given that there's iron supplements in the hospital and these women are coming to the clinic, there's something going wrong, that 95% of them are anemic in their pregnancies. So my colleague and I defined all the steps that need to happen for a pregnant woman to get treatment. So she has to arrive at the clinic, explain her problems, and that's up to the pregnant woman. And then up to the nurse, there's to analyze the problems, to test for anemia, to understand the test, to prescribe medications, and then back to the woman, acquire the meds, and actually take them. So I'm going to go through these a little bit more in depth to say, here's some constraints, and here's some things that could go wrong. So for a woman to arrive at the clinic, she needs to recognize that prenatal checkups are important. And that's a fairly new thing in the history of the world, right? This poster says, it is important for a pregnant mother to give birth in a health clinic. It is the best way to ensure a safe delivery. So these posters are here and there around, and word gets around, you need to be coming into the clinic. But most women will not come in the first trimester because people don't want to talk about their pregnancy before 3 months. Probably some of the same reasons we have in the U.S. about not announcing pregnancy till later, because there's risk of miscarriage. But once the pregnancy's obvious, she's showing, then she's more likely to go. But most women don't come until about the 7th month. And then there's money issues of transport, and then also she might have to pay for something in the hospital like the HB test, or maybe medications, or maybe pay a little tip to doctors in order to get service. And then also she has to have faith that clinics can help her in her pregnancy over her just going on her own, delivering on her own, or going to a midwife. So some women do deliver with midwife. They tend to be the people who are poor and just can't afford transportation and money in the hospital. And delivery in the hospital requires a few dollars because you have to buy gloves and possibly forceps and different needs that they just don't have the supplies in the hospital, so you have to supply them yourself. So then the woman has to explain the problem to the nurse when she's at the clinic. So first of all, she has to recognize that her symptoms are even a problem, and many women don't. They see shortness of breath, dizziness, paleness, fatigue as just conditions of pregnancy. It's just how it is in pregnancy. And, personally, I think the only condition is pregnancy is gaining a stomach. But everything else is something that can be prevented or treated, or, nutrition, exercise, something you can do. But the women just think of it as a condition, so it wouldn't occur to them to go to the nurse and say, hey, I'm feeling dizzy, I'm feeling fatigued, I can't get my work done. It's just normal. And then also the woman has to feel comfortable enough in the doctor-patient relationship to explain her problems. And this is a very difficult thing to overcome because the doctor-patient relationship is so hierarchical that the doctor has all power and the patient is there, and the doctor talks and the patient listens. And so it's not a good two-way communication relationship.
Is it gender also?
The midwives are all women, yeah.
Doctors are all women.
It depends. In Chake, there's nurse midwives who take care of the clinic. And then there's a gynecologist or two, but they're foreign. Like there's no Zanzibari trained gynecologist. So that's another problem, where currently the gynecologist is Cuban and speaks Spanish, of course, but hardly any English and hardly any Swahili. So she has to communicate in broken Swahili and broken English to the nurse midwife who speaks broken English. So it's a difficult situation and only a complicated case would even see the gynecologist. But okay, so then the nurse has to analyze the problems and the symptoms and decide what action to take. So she has to recognize that the woman has anemia or may have anemia and be knowledgeable about anemia. And then she also has to understand the seriousness of it, which I found wasn't really happening. Like all those 60 women we tested, even the ones who had 50, weren't even prescribed iron. Like they should have been referred to the doctor, to the gynecologist, to consider a blood transfusion, but they weren't even given any, you should go get iron, you should eat iron-rich foods. They were given nothing. So there's some lack of communication there and understanding. So then a woman has to go to the lab for anemia, which is another wait in line, which is another 50 cents for the test, which can be prohibitive. And then she has to be willing to be pricked, but I found most women are. So then the nurse has to interpret the test results. So the woman from the lab goes back to the clinic, and hopefully her HB was written down by the lab technician, and then the nurse understands and respects HB cutoffs, like I just said. Someone who's 50 should get a transfusion. Well, the nurses weren't respecting that. They were like, well, just, try to eat some meat. Yeah, best, which will help, but not enough. And then the nurse had to prescribe a treatment. So the nurse has to recognize the importance of treatment. And I found that the nurses weren't prescribing very much. And mostly what they would do was advise chakula bora, which is good foods. So good foods are a huge part of anemia. Iron-rich foods such as meat, fish, greens. What else? So there's some foods that are iron-rich that are good for women to eat. And I found that the nurses were more often prescribing chakula bora than iron supplements, which is vitally important to eat good food, but it's not obtainable. And women who are already anemic need iron supplements to cure it. And then also the communication, there needs to be communication about treatment and its importance. So not just say, go get chakula bora. You have to say, these are what chakula bora are. This is where you can get them. This is how much they cost. Also, the iron supplements are available for free over here in the pharmacy. This kind of stuff wasn't being communicated well, unless I was sitting there watching them and then they put on their best behavior. So then the woman has to acquire the medication. So in the hospital, medications are free if they're available. And oftentimes there's shortages or problems with money or politics or whatever that keep the meds from getting to Chake Chake Hospital. This is the dispensary from the outside and from the inside. And I sat and observed from the inside of this dispensary, and for 1 hour I recorded the numbers of every patient who came, and then the numbers of medications dispensed, and also the number of times the pharmacist said, we don't have any. So it was 45 patients, 46 drugs dispensed, and 30 times they said, we don't have that one, we don't have that one, we don't have that one. So there's an amount of frustration and lack of faith in the dispensary to have what you need. Okay, to get a little quantitative again. This dark blue line is the numbers of people to whom iron was dispensed over the course of 19 months. So you can see it fluctuated a bit, and it fluctuates on a 3-month cycle, which I can't figure out. I have no idea why. But you can see down here, it's 0 for several months. They simply had no iron. And I glanced at the months before this, and they also were 0. It was like for several months, they just had no iron whatsoever. The yellow is people who got folic acid, which is also a part of treating anemia. So usually they're dispensed together, iron and folic acid. And so I noticed that the iron and the folic acid kind of follow each other. For the months that they were both in the dispensary, they followed each other. So I did some statistical gibberish and I had predicted how much iron they would have dispensed had they had it, based on how much folic acid they dispensed. So an estimated 875 people who needed iron during those months simply did not get it. So if the hospital doesn't have it, then the woman can go to a pharmacy outside the hospital for pay, called Duka La Dawa medicine store. And their iron and folic acid there are each 1 cent a pill. 1 cent. So to us that seems entirely affordable. So a month's worth of therapeutic treatment is only about 60 cents. But sometimes that's not affordable. But these stores always have iron. There's never a shortage there. Okay, finally the woman actually has to take the medication. So in order to take it, she has to believe that it's effective and trust the medication. And she has to approve of the color, the flavor, and the smell, which seems kind of minor, but during pregnancy, smell and flavor can be a really big deal. And color can also be a really big deal for different medications, because in the past, iron was yellow in color. So women didn't want to take it because who wants to make their blood yellow? That's the bad blood. So they've changed it so the iron pills are red, so that it feels like it's a blood-building medication. So that helps. And then she has to understand the importance of it, that it will actually help her in her pregnancy. And then she has to take therapeutic amounts and for enough time, which is often very difficult. The nurses usually only prescribe 2 weeks at a time, expecting the woman will come back to get another prescription and checkup, but they rarely do. And what you really need is about 6 months worth. You need to be taking it for most of the pregnancy and postpartum. And I didn't have any pictures of iron, so I put this picture of a malaria drug, which is a 1-dose quick thing, which is really great. It would be really great if iron could happen this way, but it can't. But they just give it right in the clinic. The woman's sitting there with the nurse. She gives her 3 pills, glass of water, and she takes them right there, and she's cured of malaria. Just real quick, and they do that twice during pregnancy. And it's a great program. And iron supplements were supposed to be coupled with the same program, but it wasn't happening. So lessons learned overall. What are the overarching constraints? Back to the squiggly lines of politics and economics and stuff. So education-wise, there's little or no formal education for many women. I interviewed many women who had absolutely no formal schooling. And health education is spotty. If they have nothing but health posters, but they're illiterate, what are they going to do? And they didn't go to school to get the health education campaigns. Politically, Pemba's really messed up. They're a part of Zanzibar and they don't want to be, and they're a part of Tanzania and they don't want to be. So they're twice repressed by 2 different governments. And they're all opposition party, so they really get... the government doesn't like them at all. So there's poor infrastructure, lack of money, and often lack of motivation among hospital staff. And there's a distrust of government clinics because the government is the party and the ruling party, and everyone is opposition party. So there's just you hear stories of people saying, well, I went to the hospital and I delivered, but my baby died. And she died because the doctor was the other party and he wanted to hurt me, which I doubt is true to that extreme, but stuff like that is grounded in something. Economically, there's the inability to get to the clinic and to pay, and there's low access to nutritional foods. There are people that during certain seasons of the year eat nothing but starches, like potatoes, cassava, rice. Socially, there's gender bias, where women have less access to education, they have higher workloads, and men are the ones that go to the market to buy food. So if the man goes and brings home foods that are simply not iron rich, the woman has no recourse to change that. She just has to cook it. And then also there's the doctor-patient relationship, which I talked about already. And culturally, there's things, for example, like beliefs about pregnancy and the baby. Like some women believe that all medications during pregnancy are bad, which is a fairly safe thing to assume. You don't want to be taking anything too strong, but like they apply that to nutritional supplements. And also there's a fear that if they eat too nutritionally and take iron, that the baby will be too big and they won't be able to deliver it because C-sections are hard to get. And so women sometimes specifically don't eat foods that they think will make the baby big, which really just is healthy. You know, these babies aren't 10-pound babies, they're like 6-pound babies. So after that, is there anything positive about the situation in Pemba? So positively, prevention is possible and treatments do exist. We just have to fill this gap of getting them to the women. And some women are accessing them and it's increasing, and women are getting them even when they have to pay for them. And people do see Western pharmaceuticals as powerful. So if they can accept that iron could be a good thing if there was just a little more understanding about it. And structural solutions have been successful. For example, dispensing iron in clinics along with the malaria drugs, which has happened in other countries successfully and has increased women's birth outcomes positively. So finally, just show some pictures, wake everybody up a little. This is Juma this summer. This is a view from our back balcony over this valley that we lived in our neighborhood on a rainy day. And this is one of 5 mosques within hearing range of us. So we heard the call to prayer as many times as I hear ambulances in Connecticut, where I live. We had a huge Swahili-style birthday party for Juma, and it was crazy, but a lot of fun. And of course, I have to acknowledge my husband and my son in helping me and supporting me in everything, but they couldn't be here today. And of course, Pembans are great, wonderful people. Of course, there's people that aren't, but we were welcomed very well. And these were our neighbors. They invited us to dinner a few times, and their kids played with Juma, and we just had a wonderful, wonderful experience being welcomed there in Pemba. So I think that's it. Yeah. Okay, we just have a few minutes, but are there any questions? And Ashley has a microphone if anyone wants to.
Sorry, this is just a quick one. Is that on, I guess? The women going out to the market. Mm-hmm. In so many societies that women do that. I mean, that's one of their jobs. Is this because of purda, of hijra, is that an Islamic thing that's going on here that women stay home? Yeah,
I don't think that's on. Is it? Anyway, the question was...
Maybe just for recording.
Can you hear it back there? Yeah. The question was about women going to the market. Is it an Islamic thing? Is it a cultural thing that women don't go? Because in many cultures, it's the women's job to go. But yeah, I think it's a cultural thing. It has to do with Islam, where this is how Zanzibaris have interpreted Islam, where the marketplace is just a place for men, and women don't want to be out and seen in a place like that.
How much control
reputation-wise
do women have over, does the woman send a list? How much control does she have over what is purchased in the market? And would it do any good, I guess, so I'm thinking, to educate women if the problem is with buying whatever they want?
That's one of the huge problems. Men have to be involved in the treatment of their wives' anemia as well. How much control she has would depend on how good of a communication relationship she has with her husband. And often a woman would not feel empowered to be able to say, hey, listen, I really need some fish and some greens this time. And then also he could be very constrained by his lack of wages. But look to Islam for that, where it's Islamic law for men to provide shelter, food, and clothing for the family. So.
Hi, Sarah. I have a question about participant observation, because obviously you've done a lot of it, even contracting malaria to fully participate in the experience. But,
I caught mosquitoes and
Right, exactly. But I'm curious, you mentioned a couple of times about your presence as I'm guessing a white Western woman. In terms of your research, you referred to, if you were sitting right there, people would maybe interact with the patients differently than they would if you weren't there. I'm also curious about the way you adopted, I guess, Swahili dress and how that played into. I don't know if your research colleague also did that. Was there a difference in the way people treated you or responded to you in terms of questions and interviewing?
Yeah, there was definitely a difference. A huge difference. She covered her hair, and wore very modest clothing, skirts, and at least 3/4 length shirts. But she didn't wear the black buibui, is what it's called in Swahili, which I did. She was in a different city, and she did her master's degree research there, and so she has a different experience than mine. But people received the way I dressed very positively. They loved it. I think there's a lot of attitude from the West about Muslim women, that they're repressed and they shouldn't dress like that. And so when a Western woman adopts it, I think they were very appreciative. Like, you understand us, you understand why we do this, our level of modesty. So. At the same time, a lot of people therefore assumed I'm Muslim, which I was uncomfortable with, not because being Muslim is a bad thing, but because I felt then I might be deceiving people in a way that I definitely did not want to be doing. And a lot of people, they would say, oh, you're Muslim, or your husband is Muslim, why do you dress like this? And I would just say, I just do it out of respect for your culture and, just to be modest. And then women would say, all right, now you know how to dress. I'm going to teach you how to pray and how to fast, and then you'll be a good Muslim. And I'm like, no, that's okay. So next time I'm going to give it a lot of thought going back, if I'm going to wear the full purdah or just dress very modestly, because I don't want to get involved in any sort of deception.
Hi, Sarah.
Hi.
The question I have is, you talked earlier about the holistic conceptualization of malaria. And I remember your paper in my class, which was so excellent, and some confusion about spiritually caused disease versus the advanced stages of malaria where it can affect the brain. And so when you talk about holistic approach, the spiritual approach, I'm wondering, how do you balance that with medical needs?
Yeah. A lot of research has been done about sort of bridging the gap and involving traditional healers in, say, dispensing Western medicines or something. But a lot of the research is very supportive of the existence of traditional healers because they serve a very important need and niche within societies. So, for example, there's been programs where lay midwives will dispense iron and give education about pregnancy. And the midwife I interviewed had gotten training at the local clinic on how to cut the cord so there's no infection, what to do in such and such circumstances. So sort of like an involvement of that. But a lot of this research and practice has worked on combining the two, the Western and the holistic or community aspects. So while they say, if you have an STD, come to the clinic, get the antibiotics, and you also go to your traditional healer who will address the community disruption and fix that aspect of it as well. So they can go to both places. They get the antibiotics to cure the drug, but they also get the spiritual healing to heal the community aspect of it.
what are the local healers say about like the Western doctors? Do they feel that they're encroaching on their territory? Like, do they think that they should coexist together? And
it varies. There are doctors that would say, what are these Western people doing? They're just ruining our. But most of the time, any negative attitude comes from the Western clinics against the local doctors. Most of the time, local doctors are very willing to. They see the Western clinics as powerful and the Western medications as powerful, so they want to tap into that. And, they may say, well, I'm really good at healing such and such, but I can see that the clinic is really good at healing this other disease. So if they can tap into both of those, then they can be better doctors. So there has been a lot of collaboration that way.
Sarah, hi. My question is along the lines of bridging that gap and kind of combining the Western way to treat illness and the Zanzibar way in relation to maternal anemia and what efforts have been made. You mentioned a little bit how these how the anemia is perceived as conditions of pregnancy, and how do people explain or perceive death at delivery, and is that part of just being pregnant, or do they conceive it as part of having anemia? I guess those are two questions.
Yeah, I didn't delve into really delivery and postpartum issues. I would imagine people think that some women are just gonna die. That's just what happens. I mean, the maternal death rate is quite high, and infant death rate as well. But I think most people recognize that as a loss of blood. But then there's also issues where in postpartum, women think they have too much blood, which is why women have a flow for 6 weeks. So they see that as they need to get rid of blood, and they do things in order to do that, like eat hot foods like ginger or sour oranges, and even light fires underneath their beds to produce heat to get the blood out because they see too much. So there's a disconnect there where we're saying, you need to build more blood, when they're like, no, we have way too much. Does I answer your question?
Yes, and the other question was about how the Western and the Zanzibar way of treating anemia, maternal anemia. Are you working with some of that and I guess educating or maybe the local doctors? Or?
As far as I was able to ascertain, most women see anemia as naturalistic. So coming in with Western ways of healing that is not a problem. But there are some anemias that are caused by spirits, especially postpartum, where they want to cover up the smell of the blood because there's certain spirits that like the smell of blood, and they'll come and eat off the blood of the woman. But there are certain diseases that are just simply seen as naturalistic and not involved in the spirit world at all.
I was just wondering if you said you talked a lot about how you noticed that the women weren't taking iron. Did you ever go in there and promote it? Did you ever go in there and say, hey, this could really help you, or were you kind of just an observer from the outside? What step did you take?
Yeah, while public health practice would encourage me to be just an observer from the outside, I feel unethical doing that, where I'm talking to a woman who's severely anemic, and I'm like, okay, bye. I would try to encourage her. These are some good foods to eat. Here are some iron supplements for you to take. This is where you need to go to get more. And also right at the very end, somehow a TV reporter found me. There's not that many white women who dress in purdah in chake, so it was pretty easy to find me and figure out who I was and what I was doing. So she recruited me and my colleague we went and did a TV interview at the end of our research and talked about the issues of anemia and here's some beliefs women have, but this could really help. And so we did a lot of promoting that way that was aired on local TV in Swahili. So I hope they could understand me.
Were they more receptive to you being a white Western woman than their doctors and midwives?
I think that can go both ways. Where, I'm such a foreigner, so, she has different ways, she has different ideas. But then also there is that hierarchy, even though I don't like to be in that position. Like, I'm often seen as a patroness for people, where they would, consider me more knowledgeable or more,
Okay, one more.
It seems like through this project, you've outlined all the goals and everything that needs to be done. And so as a public health professional, what would be your job in seeing that all of these things are carried out?
Mm-hmm. Well, you could do what, or would be, you could call a downstream approach, where you could just educate the women, educate the doctors, treat. But then you're not addressing the parts that is the causes and the structural, political, economic issues. So while doctors would treat, some public health people would educate. But then I prefer to go a little further back, a little further upstream, where I would try to get in at the political level, the structural level, improve the political situation so drugs could get where they need to be. And what else would I do? Improve gender relations. There's these kind of broader outside issues that are outside of anemia specifically that need to be addressed in order for there to be fewer people that need to be treated.
So your job is really multidisciplinary, and is that you have this checklist, and now you are just going to go down and through the government and social and drug access issues, you just tackle them all?
Yeah. Or as one person, I would pick one particular aspect, such as structural interventions or social change, or so different disciplines and different public health professionals will all approach it from a slightly different place.